It is my honor today to present to you Professor Julian Gilmore. Dr. Gilmore is the head of the National Amyloidosis Centre in London, England, UK. The NAC is considered the gold standard for amyloidosis care, treatment, and research in the world. And it is a great pleasure to have Dr. Gilmore here today to walk us through a scientific update.
So it's a great pleasure. Thank you very much for the kind introduction. Can you hear me? Hi there. It's a great pleasure to be. I'm sorry I'm not with you in person, but it's a great pleasure to talk to you today. I'm just hoping that you can hear me okay. I'll assume that you can. So thank you for the kind introduction. I'm going to talk about new advancements in the care of ATTR amyloidosis, and I'm going to focus mainly on treatments and advances in treatment. I will talk a little bit about diagnosis at the end, but I'm going to focus mainly on treatment. These are my disclosures. So I'd like to start by explaining that all of the approved and established treatments, if you like, for any form of amyloidosis are focused at trying to slow ongoing amyloid formation, so address this part of the pathway. And one can do that. The most established way of doing that is to reduce the supply of the amyloid, the protein that makes the amyloid in the bloodstream. And the second way that one can do that specifically in ATTR amyloidosis is to stabilize the TTR protein. And the idea in ATTR amyloidosis is that the TTR protein is almost exclusively made by the liver. And so one can give gene silencers, antisense oligonucleotides they're known as, or RNA interference therapeutics, they're known altogether as gene silencers, to reduce the production of TTR by the liver and thereby reduce the concentration of the TTR protein that's available, if you like, to make new amyloid. The second option is that the TTR protein is secreted as what we call a tetramer. It's like a four-leaf clover. And in order to make amyloid, it has to fall apart or be cleaved, be cut into what we call monomers, 4 bits, if you like. And there are some drugs, tafamidis and acoramidis, which basically stabilize this tetramer so that it is less likely to fall apart into these monomers, which are the bits that make amyloid. And finally, experimentally, there are some drugs, they're known as antibodies, that are designed to address this part of the pathway. In other words, try and accelerate this natural rate of amyloid clearance, which in patients is always slow. If you don't give treatment, the rate of amyloid formation always exceeds the rate of clearance. So that's why the condition gets worse without treatment. But what we're trying to do here is either slow this one or accelerate clearance. And this is what these experimental treatments, and I'll talk a little bit about those at the, towards the end of the talk. So I think many of you will be aware that the seminal trial in ATTR amyloidosis affecting the heart was known as ATTRACT, and that was looking at the drug tafamidis. And essentially, patients with ATTR amyloid cardiomyopathy or a cardiac ATTR amyloidosis were given 2 doses of tafamidis versus placebo. And they, at 30 months, the primary endpoint of this study was mortality and frequency of cardiovascular related hospitalizations because of a cardiac problem. And this study met its primary endpoint. So in other words, plus they pooled the 2 doses of tafamidis, and the patients on tafamidis did better in terms of the combination of the mortality and frequency of cardiovascular hospitalizations. But the study also showed that tafamidis reduced mortality and it reduced hospitalizations individually. And the panels on the right show a slowing of the decline in functional status as measured by 6-minute walk tests. Many of you will perhaps have experienced having to walk up and down a corridor to see how far you can walk. And if you have ATTR amyloid cardiomyopathy and you're not on treatment, then your ability to walk goes down, as you can see from this curve, and on treatment it goes down a little bit, but certainly much more slowly than it does over time without treatment. And at the bottom here is the effect on quality of life as measured by the KCCQ, that's a quality of life questionnaire. And essentially, again, you see that the drug slowed down the decline in quality of life as measured by this questionnaire. So unequivocal benefit associated with this drug. This slide is from the open label extension study of ATTRACT, and it tells us two things. One is that there is room for improvement. I told you it's unequivocally beneficial, but nonetheless, there are unfortunately patients who are continuing to die with this condition despite tafamidis, so there's room for better drugs. And the second thing is that you can see that the patients in blue here who were on the placebo and only started the drug at month 30 in the open label extension don't regain what they've lost. So that is also telling us that we need to diagnose this condition early and we need to start treatment early. So those are the two messages related to the open label extension. So acoramidis is a new or newer, I should say, stabilizer. It was designed specifically on the basis of a naturally occurring genetic mutation in the TTR gene that has been shown to stabilize TTR naturally and has also been shown to protect patients who carry a TTR mutation, another TTR mutation, and are likely to get the disease, to protect them from developing the disease, ATTR amyloidosis. So the evidence in population studies is that this naturally occurring variant is stabilized and that stabilization prevents onset of the disease. And on that basis, the drug was created to mimic, if you like, that naturally occurring stabilizing variant. And this is data in vitro, so in vitro means obviously not in the human body, this is in the laboratory. And essentially what it shows is that at the concentrations of the two drugs that one achieves when they're taken by tablet, the acoramidis essentially is a better stabilizer than tafamidis. So it's a more effective stabilizer of the TTR protein than tafamidis. This is data from patients who were in the ATTRibute-CM study, and I'll tell you more about that study in a moment. That was the phase 3 clinical trial in patients with ATTR amyloid cardiomyopathy. And what it shows, so what we believe is that the increase in serum TTR, so the increase in TTR concentration in your blood, reflects how well the TTR protein has been stabilized. In other words, the more stabilization, the higher the increase in TTR protein. And you can see here that acoramidis achieved a greater increase in serum TTR than the patients who received tafamidis. The patients in the study were allowed to receive tafamidis after 12 months in the study. And those on placebo started tafamidis, they had their blood measured, and you can see that the increase in serum TTR is less than it is with acoramidis. And in the patients who were already on acoramidis in the trial and then had tafamidis after 12 months, you can see that the increase is about the same as it was on acoramidis alone, suggesting that acoramidis results in near complete stabilization of the TTR tetramer. So all data suggesting that that acoramidis may be superior to tafamidis as a drug. This is the design of the phase 3 clinical trial. So it was in patients with ATTR, cardiac ATTR amyloidosis, both hereditary and wild type. And essentially they were randomized 2-to-1. So 2/3 of patients got acoramidis and 1/3 of the patients in the trial got placebo. And the primary endpoint at 30 months was an analysis, and it was what we call a hierarchical analysis. So if you like, the ones at the top of the analysis are looked at first, and if there's a tie between a patient on drug and placebo, then you move to the second aspect of the hierarchy, as it were. And so it was all-cause mortality followed by cumulative frequency of cardiovascular hospitalization, so hospitalization because of a heart problem, and then the change from baseline in the biomarker NT-proBNP, which is a blood test, and the change from baseline in 6-minute walk distance. And so and then the study after 30 months was followed by an open label extension where all patients got acoramidis. And these are the primary endpoint results. So essentially the study met its primary endpoint and with a win ratio, it was highly significant with a win ratio of 1.8. A win ratio just tells you that, it doesn't tell you how great that effect is, but if you like, what it tells you is there's definitely an effect related to acoramidis of improvement in outcome related to that primary endpoint. And I'd like to draw your attention to the last 2 items of this. So if you look just at mortality and rate of hospitalizations, acoramidis was significantly better than placebo just using those 2 aspects of the primary endpoint. So most of the ties, as it were broken by the first 2 endpoints, if you like, which are what we as doctors say are the hard endpoints, of the clinical trial, as it were. And I'm glad to be able to tell you that the drug was associated with an excellent safety profile. This is just another way of looking at the primary endpoint. So it's just a different way of analyzing things, but essentially it shows the same thing, that the patients on acoramidis did very significantly better than the patients on placebo. And it's worth just mentioning that the curves begin to diverge at 3 months. And what this means is that in order to prevent either a death or a hospitalization, you need to treat 7 patients with acoramidis. And actually there was a 36% reduction in that outcome measure, if you like. And in terms of reducing the annual frequency of cardiovascular hospitalizations, there was a 50% reduction in hospitalization. So very good evidence that if you're on acoramidis, you don't get hospitalized as much, and there's a 50% reduction in the chance. And in terms of how many patients do you need to treat to prevent a hospitalization, it was only 5. So very strong results suggesting important findings from acoramidis, important benefit. This is the rise in NT-proBNP. So I told you, I think that the NT-proBNP is a biomarker, it's a blood test. And what we see in untreated patients is that it rises with time as the condition gets worse. And acoramidis slowed down that rise. And this is the decline in walk test. And you can see that although it does decline on acoramidis, it declines far less than it does on placebo. And actually there was a 40-meter difference in 6 minutes between patients on acoramidis and patients on placebo by 30 months. So a very significant difference in distance between patients on treatment and patients on placebo. This is the change in quality of life. And again, overall, the decline in quality of life was markedly slowed by acoramidis, but perhaps most importantly, actually nearly one-third of patients had one-third of patients on acoramidis, actually their quality of life improved across the course of the study. So, significant improvements in a proportion of patients. Unfortunately, not all patients, but nonetheless a proportion. And this is just data that shows that the drug actually benefits pure survival as well as the combinations that I've mentioned earlier. If you follow patients for a bit longer, there's a statistically significant benefit in survival as well as hospitalizations, as well as quality of life and functional status. This is a study that we did. It's what we call a sub-study. So it was only in a small group of patients who are in the trial. But I'd like to focus your attention on this panel here. ECV stands for extracellular volume, and extracellular volume, we believe, is the best way to look at the quantity of amyloid in the heart. And what we know is that if the extracellular volume falls by more than 5%, that is associated with survival benefits. So in other words, if a patient has significantly less amyloid in the heart as a result of treatment, then that is associated with a survival benefit. And what we saw in this small sub-study, and you can see that those are the patient numbers at the bottom, they are very small, but no patient on placebo had a reduction in extracellular volume of more than 5%, whereas 3 out of the 24 did have a reduction in extracellular volume of more than 5. So, evidence that some patients are actually regressing. They're getting into an equilibrium where they're getting rid of amyloid more quickly than they're making it, and therefore overall their amyloid is diminishing. This is just showing you, I told you that acoramidis causes an increase in the concentration of TTR in the bloodstream, and this just shows you that that was the case in the clinical trial, and the increase that is evident by day 28 after starting treatment is sustained throughout the clinical trial to month 30, whereas obviously the placebo patients don't have an increase in serum TTR. Now, this is somewhat recent data, and it's more at this point of interest than necessarily being firm. But what we did notice in this study is that the patients who did best were the ones who had the greatest increase in serum TTR by day 28. So the higher, the greater the increase from baseline in serum TTR, the better patients did. And when we use some complicated statistical techniques to look at this, what we discovered is that for every 5 milligram per deciliter increase from baseline in serum TTR at day 28, there was a 31.6% reduction in mortality. So a preliminary evidence that one might be able to use serum TTR as a marker of a response to treatment. So perhaps in the future, if we've got more data, it may be that we can measure serum TTR, put a patient on acoramidis, and then remeasure the serum TTR 28 days later and have a good clue whether they're responding well, which is particularly important in the context of us having more than one treatment for this disease, because obviously that might help one to decide, okay, this patient's not responding very well, let's consider a switch to an alternative treatment. Turn my attention to the gene silencers. So, there have been quite a number of gene silencers. They all, as I mentioned earlier, they all are designed to knock down, reduce the concentration of the TTR protein in the bloodstream. The idea being that if you've got no TTR protein in your blood, you've got nothing to make more amyloid, to make more amyloid, which will deposit in the heart or the nerves, etc. And these are outcome studies with the 4 gene silencing drugs. that you can see at the top there. And just to take you through what they mean, these on the y-axis here is what we call MNIS plus 7. That is basically a neuropathy score. And essentially what you see is that in all the placebo patients, the neuropathy score unfortunately gets worse. The disease is getting worse, the neuropathy score increases. But what you see with the drugs in the treated patients is that the neuropathy score either stays stable or gets better, or rises much less significantly. Very highly significant difference in all of these studies between the patients on placebo and the patients on the drugs. So Helios B was a study that tested one of these gene silencers, the vutrisiran, in patients with ATTR amyloidosis affecting the heart, ATTR amyloid cardiomyopathy. And it was the first study to look at hard outcomes in cardiomyopathy patients. And essentially, in terms of the design, it was hereditary or wild type ATTR amyloidosis who were randomized to vutrisiran or placebo. And again, the primary endpoint, the thing that determined the statistical value, if you like, of the study was the combination of all-cause mortality and recurrent cardiovascular events. So quite a similar design. And the secondary endpoints were the change from baseline in walk test distance, the change from baseline in quality of life, and then some individual components, as you can see there. And again, the study was followed by an open label extension. And this study also met all of its endpoints, all 10 primary and secondary endpoints. So in other words, this study confirmed that vutrisiran doesn't only benefit neuropathy, as I showed you earlier, but it also definitely benefits patients with ATTR amyloid cardiomyopathy. And again, it was associated with a reduction in risk of mortality, a reduction in risk of hospitalizations, a slowing of the decline in walk test, a slowing of the decline in quality of life, and again, a slowing of the rise of NT-proBNP that I explained to you earlier is associated with disease progression, and this rise in NT-proBNP that occurs in the absence of treatment has been shown to be associated with outcomes, mortality, etc. So again, evidence that this drug vutrisiran is beneficial, unequivocally beneficial in ATTR amyloid cardiomyopathy. This is from a paper that we published literally a couple of weeks ago. And I'd like you to focus on the placebo patients, because what this is showing us is that the placebo patients, the patients who weren't on drug, you can see from ATTRACT, which was way back published in 2018, to ATTRibute 2024, to Helios B 2025, the placebo patients shown by the dotted lines are doing better and better. So the management, and that means two things. One, patients are being diagnosed earlier, and the supportive management of patients is improving, and patients' outcomes are doing better. What you also see is benefit. In other words, the lines are going down in this case because mortality is going up, if you see what I mean. So the lines in the treated patients are going down in each of the study compared to placebo. Each of these studies, the solid line is the patients are doing better. But I think it's fair to say that we can't, on the basis of these studies, they've never been compared head to head. One of the questions that I'm sure you will have is, which is the best drug? And we tried to look at that, and essentially there's really no evidence that one drug is necessarily better than the other. There might be some suggestions, and I've suggested that, in vitro, some of the drugs are better, but I think on the basis of these particular trials, that's all we can say, on the basis of these particular trials, which were conducted in different groups of patients, we can't necessarily say that one drug is definitely better than the other. And I think, one thing to mention is that we know that even acoramidis, which I told you is a good is a better stabilizer than tafamidis in vitro in the laboratory, even acoramidis doesn't completely stabilize TTR, and vutrisiran doesn't completely get rid of TTR from the bloodstream. So in effect, there is still some TTR monomer, there are still some TTR monomers, if you like, so some fragments of TTR that are available to make more amyloid. And what we do know from studies in all other types of amyloid that we've ever looked at in detail is that if you're using an agent to knock down the precursor protein, so like the gene silencers that I've mentioned, the greater the knockdown, the better the outcome. Okay, so these are patients with a condition with AL amyloidosis, and you see that the patients who achieved what we call a complete response, what hematologists call a complete response, which is like 100% knockdown, they did exceptionally well. And patients who achieved 90% knockdown, between 90 and 100%, did well, but not quite as well as the 100%. And these are patients in the yellow line, 50 to 90%, and these are patients less than 50%. So you can see there's a direct relationship between how effectively you knock down the relevant protein and outcome. And exactly the same is true in AA amyloidosis. The more you knock down the protein SAA, that's the protein that makes the amyloid in this form of amyloidosis, AA amyloidosis, the more you knock it down, the better the outcome. And similar data is emerging in ATTR amyloidosis. We believe that the same will hold true. The more you knock down the TTR concentration in the bloodstream, and I should say, just to avoid confusion, with a stabilizer drug, you're actually trying to increase TTR, and that's a measure of effectiveness. But with a gene silencer, your measure of effectiveness is how much you knock it down. You want to decrease the TTR in the bloodstream. So, you know, that's important to be aware of, that you're looking for the opposite effects in terms of their benefit in patients on silencers or stabilizers. And this is just to show you that amyloidosis is a dynamic process. I showed you right at the beginning that the body does get rid of amyloid, although very slowly, and you know the rate of production in the absence of treatment always exceeds the rate of removal, so that amyloid builds up. This is a patient who had a specific technique that we developed in our center called SAP scintigraphy. It's a way of looking at amyloid in the major organs. And unfortunately, it doesn't look at the heart, so we can't comment on the heart using this technique, but it looks at amyloid. This is a patient who presented with massive amyloid in the liver, the black bit, and the spleen here. And you can see that the patient had chemotherapy, which is the treatment for this form of amyloidosis, AL amyloidosis. They achieved a complete response, so 100% knockdown. And you can see that less than a year later, the amyloid in the liver has basically completely gone away, and the amyloid in the spleen has diminished very markedly. Not completely, that's still an abnormal spleen, but it's diminished markedly compared to the spleen here. And unfortunately, this patient had a hematologic relapse, so the underlying condition came back, and you can see the amyloid starting to build up again in the liver. Unfortunately, he wasn't treated very quickly, and half a year later, his amyloid had built up almost back to baseline. So you can see, I'm just showing you that it's a dynamic process. Amyloid can go away. If you stop production completely, then you can get into an equilibrium where you're getting rid of amyloid more quickly than you're making it. And this is using cardiac MRI. So Mariana Fontana, Professor Fontana in our center has really taken cardiac MRI and used this extracellular volume, which I told you earlier is, we believe, the best way at looking at the burden of amyloid in the heart, and was able to show that in patients with AL amyloidosis who have cardiac involvement, if they achieve it, well, in order to get regression of amyloid, an improvement in extracellular volume, a significant improvement, they need to achieve either a complete response or what we call a VGPR, at least a 90% knockdown of the precursor protein. And perhaps the same is true in ATTR amyloidosis. And I told you that at the moment, the gene silencers cause or bring about around 80% knockdown. So maybe more knockdown will turn out to be better if we can achieve or establish drugs that knock down the TTR protein even more effectively. So if you like, I'd like to focus on this side of this slide. And here we have the rate of production in the absence of treatment. We've got the rate of production here, and we've got the rate of clearance in blue here. And you can see that the rate of production of amyloid always exceeds, in the absence of treatment, the rate of clearance. And so what you have is the amyloid burden, the amount of amyloid in the body is gradually increasing, as shown by this thick blue line here. If you give treatment to slow amyloid formation, either a stabilizer or a gene silencer, in a patient who has quite a good rate of amyloid clearance. No one clears it quickly, but some people do clear it more quickly than others. And if you give a drug to slow the rate of formation, as you can see here, amyloid formation, you might get into an equilibrium where the rate of clearance exceeds the rate of formation, so that overall the amyloid burden is gradually diminishing. But if you have a patient, as you can see here, with a slow rate of amyloid clearance, even if you reduce the rate of amyloid formation, they might still be making amyloid a bit more quickly than they're getting rid of it. So although you'll slow the rate of amyloid accumulation, they will still be accumulating amyloid very gradually, more gradually than they were before treatment, but nonetheless they will still be accumulating amyloid. But it may be that if you can stop production more effectively, even in that patient, you'll get into a situation where they're clearing amyloid more quickly than they're making it, and so the amyloid burden is diminishing. And that leads me to this CRISPR-Cas9 based gene editing therapy. So we tested this drug, which is now known as nexiguran-ziclumeran, or Nexz, which is given as a single infusion, a single intravenous infusion, and it edits the TTR gene, specifically edits the TTR gene so that no or very little TTR protein is made. And it has the potential to do that after a single infusion and last forever. And we studied this drug in a two-part study of patients both with hereditary ATTR amyloid polyneuropathy, the neuropathic form of the disease, and patients with wild-type and hereditary ATTR amyloid cardiomyopathy. It was 72 patients in total. It had a two-part design, but the primary objective of this what we call phase 1 study, a first-in-human study, was really to make sure that the drug was safe and tolerable, and then really to see what effect it had on TTR levels. And then the secondary objectives were obviously to look for potential clinical benefit. So a phase 1 study is really all about safety. A phase 3 study, 2 and 3 studies are more about outcomes, clinical outcomes. And that's what the earlier studies that I showed you were really phase 3 clinical trials. So in this phase 1 study, this was the effect of one shot of Nexz given on day 1 on serum TTR levels. And you can see that in all patients, there was a very marked and rapid reduction of serum TTR, which equated to greater than 90% reduction. So really, impressive knockdown in all the patients that were treated with this drug. What effect did that have? What does that mean for the patients, most importantly? Well, this is the 36 patients who had cardiac ATTR amyloidosis. And the first thing to say is that we treated a very advanced group of patients in this clinical trial. It was a different group of patients than the ones that I've presented in the earlier phase 3 clinical trials. In other words, 50% had very significant heart failure at baseline, and what we call NYHA class 3. So they were very impaired physically, and more than just about a third of patients had the hereditary form of the disease with one particular variant, which is known to be rather more aggressive than the wild type disease. And so essentially this is a more severe group of patients, and despite that, at 12 months, their NT-proBNP was completely stable, as was their troponin T, so their biomarkers in the bloodstream were stable. If anything, there was a slight improvement in KCCQ, the quality of life measure, and the walk test distance from baseline over the course of 12 months stayed completely stable. So a suggestion, and this is certainly not enough to say this drug is better than the existing drugs. You need a lot more information than this, but it's certainly encouraging that it could be. You've got greater knockdown, and maybe that is translating into better outcomes. This is the neuropathy patients. So this is the 36 patients with neuropathy, and essentially this is the mNIS+7 score. So it's the neuropathy score that I was talking about earlier, and a reduction in the score of more than 4 has been shown to be clinically meaningful, as it were. And you can see that most patients in this study, and even including some patients who had had prior disease progression on patisiran, one of the gene silencers, most patients in this study had improvement, and most clinically meaningful improvement in their neuropathy score. 72% of patients had clinically meaningful improvement in their neuropathy score. So evidence again of significant benefit. The drug in this phase 1 study was safe. There were treatment-related adverse effects, the commonest of which was infusion-related reactions. So typically a headache or a bit of fever during or immediately after the infusion, but these all resolved without complications or sequelae. There were 2 patients in the cardiomyopathy arm that developed, and 6 patients in the neuropathy arm who developed some abnormal liver blood tests. And I think it's important just to say that at the moment, the phase 3 clinical trial has been paused because of a recent event where a patient developed quite significant abnormal liver blood tests. So that's been paused, for reasons of caution. And the aim is that the sponsor, the company, will need to explore this in more detail to make sure and try and mitigate that possible adverse effect. This is the phase 3 clinical trial that I'm talking about. It's known as Magnitude. Patients were randomized 2-to-1 Nexi to placebo. The primary endpoint is similarly to do with mortality and cardiovascular events. And in terms of this study, we don't know exactly how long it's going to last because it's what we call an event-driven study. It will stop after a number of events have happened, as it were. I will turn my attention to a 3rd generation RNA interference therapeutic. So Alnylam have come up with a third. We had patisiran, then vutrisiran, and this is the third one, nucresiran. And data about this drug, phase 1 data, was presented about a year ago now, and the phase 1 trial, again, which is concentrating on safety, but at the same time is looking for signals of possible efficacy, and this was given to healthy volunteers, so you can't look at efficacy in terms of amyloid, but you can look at efficacy in terms of TTR levels in the bloodstream. And essentially what this showed is that the administration of nucresiran resulted in 97% knockdown of serum TTR. So even better knockdown of serum TTR. And this drug is given once every 6 months by a little injection under the skin. And there will be trials of nucresiran both in cardiomyopathy and polyneuropathy open, I think, by the end of this year, or if not, early next year. So that looks exciting. What about combination treatment? And it makes logical sense, at least, to think about knocking down TTR with a gene silencer or gene editing in the future, and then stabilizing whatever TTR is left with a stabilizer. So what about combination therapy? Now, I think it's really important for me to say to you that at the moment, we don't have any evidence that combination treatment is better than monotherapy, than one or other drug alone. That's not to say that won't turn out to be the case, and I think we may get an answer about whether combination therapy is or isn't superior to monotherapy in about a year's time, when a new trial called CardioTransform that some of you may be aware of in patients with ATTR amyloid cardiomyopathy are taking part, when that reports, as it were. So the main message about combination therapy is that we don't know yet whether combination therapy will be superior to monotherapy. I'm going to turn my attention to the other aspect, the experimental treatments to try and accelerate removal of existing amyloid. So in other words, to try and reverse the disease, which is really pretty exciting. It's a pretty exciting possibility to think we might be able to reverse disease. And we've had a long interest in our center in antibody treatment. So giving an antibody to try and bind to amyloid and thereby potentially reverse the disease, cause a more rapid removal of existing amyloid. And we did a study, we developed a drug and did a study in first in a mouse model of amyloidosis, and that was successful. And then we did a study in patients, a phase 1 study, and we were able to show that the drug was safe. I told you phase 1 is all about safety. The drug was safe, and we were able to achieve pretty rapid removal of amyloid from the liver, spleen, and kidneys. The phase 2 study was aiming to remove amyloid from the heart, but unfortunately, we didn't manage to do that, and the drug that was the trial and the drug was bought by GlaxoSmithKline, and they dropped the drug. So it was disappointing for us that this drug was dropped, but more importantly, it was a proof of principle that if we could get an antibody to amyloid and bring about what we call an immune response, so interest the immune system in a patient's amyloid, if you like, we could achieve rapid removal of amyloid. And that brings me on to a number of trials of what have come to be called depleters. They are drugs to try and deplete the amount of amyloid, if you like, or remove amyloid. And this is data from a phase 1 trial using a drug that was originally known as NI-006, showing pretty exciting results. So the results to 12 months showed an improvement in NT-proBNP, the biomarker, the blood test that I was telling you about, but also looking at using this extracellular volume on cardiac MRI. There were patients who had quite a marked reduction in their extracellular volume, suggesting that their amyloid, the quantity of amyloid in their hearts was diminishing. And essentially, this is data from beyond 12 months in that phase 1 study. The drug had a favorable safety profile, and you can see that some of the patients had a very marked reduction in extracellular volume, suggesting that their amyloid is significantly diminishing, as it were. And this drug has been tested now, or is being tested, I should say, in a phase 3 clinical trial. So phase 3, as I mentioned, is really is the final phase before a drug gets approved, and it's really aimed at looking, does the drug benefit outcomes? And that trial is fully recruited. Some of you may be aware of it or even may be in it. but we await the results to see whether this drug really can reverse the heart disease, which would, of course, be a wonderful outcome. I'm encouraged that these antibody therapies might do exactly that, because we discovered a few years ago a patient and then subsequently two more patients in our center who basically came to us with classical heart failure, symptoms of heart failure, breathless, fatigued, swelling in the legs, etc., and was diagnosed, all three eventually diagnosed with ATTR amyloid cardiomyopathy, or cardiac ATTR amyloidosis. They had classical features with an abnormal bone scan, an abnormal cardiac MRI, an abnormal echocardiogram, elevated NT-proBNP, etc. And essentially, without giving them any treatment at all, we discovered that they cleared their own amyloid. So this was a completely remarkable finding. We've got more than 5,000 patients with cardiac ATTR amyloidosis, so this was an incredibly unusual finding. And we decided to try and identify, how come these patients have got better of their own accord, spontaneously. We don't normally see this. And we discovered that all three of the patients had developed an antibody. Their immune system, if you like, had developed an antibody against their own amyloid. Why it happened in these three patients and doesn't usually happen, we don't know. But at the same time, it strongly supports the idea that antibodies can get rid of amyloid in the heart. And what was even more encouraging is that it showed for the first time that if you remove amyloid from the heart can actually recover. So, it is worth trying to accelerate this removal of amyloid from the heart, because the heart can recover. You're not left with a big baggy heart that doesn't do anything. Now, that's in these three patients. We need to be cautious, but at the same time, I would say it's extraordinarily encouraging. I've talked to you a lot about treating the disease, but obviously prevention is better than cure, isn't it? How can we prevent patients from getting this disease? And this is an exciting study known as ACT Early, in which carriers of TTR genetic mutations, so genetic mutations that put them at risk of developing ATTR amyloidosis in the future, are randomized to acoramidis or placebo. And the idea is to show that acoramidis can prevent onset of the disease. So that would mean that in the future, one might be able to treat patients who carry a genetic mutation and are at risk of developing the disease with acoramidis to prevent onset of the disease, as it were. So the first real prevention study in ATTR amyloidosis, which is really exciting. What about in cardiomyopathy? Well, one of the way-ins to a future prevention study, I think, will be through carpal tunnel syndrome. We know that patients with ATTR amyloidosis affecting their heart, a very high proportion of those have had or did have carpal tunnel syndrome a good few years before developing the heart disease. And we've conducted a study very recently, it's yet to be published, in which we took unselected individuals over the age of 50 with carpal tunnel syndrome who were going to have a carpal tunnel decompression. And we asked the surgeon doing the carpal tunnel surgery, rather than throwing any tissue that they took out of the wrist into the bin, we asked them to make what we call a histological block and send it to us for amyloid staining. And somewhat incredibly, we discovered that 39% of those unselected patients, men, women, unilateral or bilateral carpal tunnel syndrome, we included anyone and everyone over the age of 50. 39% of them had amyloid deposits in their wrists, and the vast majority of those were ATTR type amyloid. And the ones with amyloid in their wrists, we asked to come back for a cardiac evaluation, and we discovered pretty frighteningly that 28% of them already had some evidence of ATTR amyloid in the heart, but that most of those patients had what we call a grade 1 DPD scan. That's the form of bone scan that we do in the UK. And most patients were completely asymptomatic. So this is perhaps a way in to find early patients before they get symptoms and then potentially, treat them with drugs to prevent onset of a significant heart disease, if you like. This also gives us some pretty frightening potential numbers in terms of the prevalence of the disease. And I won't go through it in detail, but suffice to say that there are more than 25,000 carpal tunnel decompressions done in the UK in individuals over 50 years old. And if you do the maths, it means that there are a lot more patients out there that should be being diagnosed than are currently being diagnosed. And even more frighteningly, to some extent, is the fact that apparently I heard the other day that only 20% of patients with carpal tunnel syndrome actually ever have surgery. So if you start doing the maths of the potential numbers of patients out there, it might actually be very, very substantial. I'm going to finish off just by summarizing some unanswered questions, some areas that we still don't have the answers to. And I think the first thing to say is silencers versus stabilizers. Which is better? I think I did highlight earlier, we've had no head-to-head studies, and I don't think we can say on the basis of the data we have that one drug is better than the other. What about acoramidis versus tafamidis? I showed you that acoramidis seems to stabilize TTR more effectively in vitro in the test tube, but does that translate into better outcomes? Well, again, it may do, but at the same time, I can't tell you that it does because we've had no head-to-head studies. So we need to be circumspect. What about combination therapy versus monotherapy? Using a combination of these drugs. Again, as I mentioned earlier, we still don't know whether combination therapy will be superior to monotherapy. Does the degree of TTR knockdown with the gene silencers, does it matter? I hopefully provided you with some information to suggest that if we knock it down by more than 90%, I expect outcomes to be even better. But we still haven't proven that. And that's going to be probably quite a difficult thing to prove because, again, we have no head-to-head studies to say actually, patients who received this drug and achieved 90% knockdown did better than patients who achieved 80% knockdown than this drug. But what we may eventually find when we've got enough patients is that we can look at patients in terms of how much knockdown they achieved in any of these trials and start to understand whether what stands true in other types of amyloid is also true in ATTR amyloidosis. I told you that patients amyloid regression, removal of amyloid occurs slowly in everyone, but nonetheless, in some patients, it does occur more slowly than other patients. We don't know what determines the rate of clearance of amyloid in patients. So there's a lot of work to be done there. And now that we're going to have more than one treatment for ATTR amyloidosis and specifically for ATTR amyloid cardiomyopathy, we need to be able to define people who are not responding well, which is not something that we, to some extent, unfortunately, with one treatment, whether we could or not, didn't make a huge difference. But now, if we've got the possibility of switching to an alternative treatment, it would be nice to have features that mean that we can define a patient as not responding and then switch them quickly. And this data here at the bottom is just thinking about ways, it's a study that we conducted recently, thinking about ways to define people who may be non-responders so that we can think about switching to an alternative treatment. And finally, I've talked to you a lot about what we call the disease-modifying therapies, the therapies that specifically address amyloid, but what about all the supportive therapies? And, on the basis of time, obviously, I haven't got time really to talk to you a lot about supportive therapies. So I think, to summarize, it's an exciting time for the ATTR amyloidosis field. And, what is unequivocal is that patients are doing better than they were even 3 years ago. and definitely 5 years ago and definitely 10 years ago, the outcomes are getting better and better. They're not good enough yet. We've got a lot more work to do, but nonetheless, outcomes are improving. And the number of drugs that are going to be available very shortly is increasing, and there are a number of even more promising looking drugs, which I've touched on today, that will hopefully become available in the not too distant future. So I think it's I'd like to finish on an optimistic note. I think that we've got better and better drugs. We're diagnosing the condition more and more, and we're diagnosing it earlier. But nonetheless, there is still a lot of work to do so that we diagnose the condition even earlier, hopefully even get to a point of preventing the condition in most patients. So really identifying it and establishing the diagnosis early is still, I think, the most important aspect so that patients can maximally benefit from treatment. And so I'd like to just finish off by acknowledging all my colleagues in the centre with whom I work. I've got an amazing team at the centre, and I'm just very lucky to work with so many inspirational people. So thank you very much indeed for listening, and I'm very happy to take any questions that you may have.
Hi, Dr. Gilmore. Thank you very much for your excellent presentation. I want to go back to that piece of information you put up where you showed that a few patients endogenously cleared amyloid. And so I have a hypothetical for you. And I was curious if there's a reasonable possibility to propose development or at least investigation of an mRNA therapeutic vaccine against amyloid clearance, because you did discuss depleter therapy, and you did mention that there is a reasonable proposal of endogenous clearance. So I'm curious if that could be perhaps manipulated through therapeutic vaccine. Curious about your thoughts.
It's a fantastic question, and it's absolutely an area that you can imagine we're very interested in. Could one vaccinate to develop, to encourage, I should say, development of antibodies against ATTR amyloid? So, it's certainly an area that we're, actively pursuing in, from a research perspective. And, I think your question is very pertinent. It's rather early, to be able to say that this is going to be available, next week type thing. I think that would be a bit too optimistic, but nonetheless, again, that would be potentially another way of preventing the disease, wouldn't it? If you could, use a vaccine to encourage production of antibodies against ATTR amyloid, so that if they do appear at any stage, you clear them via your own immune system. So your question is spot on, and it's just something to look out for in the future.
Any further questions? One more over here.
Thank you so much for your presentation. I'm curious about the depleter technologies and their ability to clear amyloid tissue in the nerve specifically. I really haven't seen a mention of that in the literature.
So I couldn't hear your question brilliantly, but I think you were asking me, do patients clear amyloid from the nerves? Is that correct?
That's correct, yes.
Yeah. So I think the first thing to say is that measuring clearance from the nerves is quite difficult, because we don't have an easy imaging technique, if you like, to, identify amyloid in the nerves. And most patients have amyloid in the nerves confirmed via a biopsy, ultimately a nerve biopsy, which is really the only way to be 100% sure, I should say, of amyloid in the nerves. And obviously a biopsy just gives you a very selected bit of the nerve, and it doesn't really give you an overall picture of what's going on throughout the nerves. Do you see what I mean? So the answer to your question is that it's a very difficult thing to monitor, but we have no reason to suspect that clearance from the nerves is any different to clearance from other organs, although you may have noticed that on the SAP scans that I showed you, that patient that got better and then got worse, you may have noticed that the rate of clearance from the liver was more rapid than the rate of clearance from the spleen. There was still some amyloid in the spleen when the liver amyloid had gone away completely. So we know that the rate of amyloid clearance does differ in different organs. I'm sure that the nerves will clear it, but what we don't really have a handle on is how effectively they clear it. The final and perhaps most important thing about the nerves is that, unfortunately, the peripheral nerves are not the best at regaining function. So even if you did clear amyloid completely from the peripheral nerves, unfortunately, they don't recover, if you see what I mean, in terms of their function. So once you've got, once you've got a lot of nerve damage, even getting rid of amyloid, unfortunately, is not going to reverse that symptom, if you see what I mean. So I think that that only heightens the need, if you like, as we were saying earlier, to treat patients before they've got significant disease or before they've got bad nerve disease, because achieving reversal of the nerve disease, even if you achieve reversal of the amyloid, achieving reversal of the symptoms is almost impossible, at the moment.
Thank you.
Anyone else? All right, another one over here.
Thank you. That was excellent. Question on the patients that you had with carpal tunnel that you just had no symptoms but found they had amyloid and then found out they had early stage cardiac disease. What were they treated with?
So at the moment, we in the UK can't treat those patients with any drugs. They don't have that; they're asymptomatic, and unfortunately, our payers or NICE who approve treatments approve the drug for heart failure and ATTR amyloid cardiomyopathy. Or heart failure in the context of ATTR amyloid cardiomyopathy. So at the moment, we're having to monitor those patients. Obviously, what it does mean is that we're monitoring them very carefully, and as soon as they get a whiff of heart failure, in other words, as soon as they get a whiff of a symptom, we'll put them straight on whatever we can use. But at the moment, the majority of those patients are not on treatment. Obviously, the ones who were discovered and were already symptomatic, they're all on tafamidis, which at the moment is the only available treatment in the UK. A few of them have gone into clinical trials, but they're all on tafamidis.
Thank you.
Anyone else? Oh, yes.
Really appreciated your presentation. Any of the clinical trials that are being planned, are any of them planned to come to Canada?
I think they are. I would hope they are. I believe they will be. Yeah. I don't know the answer to your question for sure, but there will be people sitting very close by to you that will know the answer, I think.
I have a question. If you have been tested, in my case, my grandmother and my mother have amyloidosis, so my brothers and I and our cousins are all going to get tested. Have you done any studies on what percentage of people have the gene but don't develop the disease?
Yeah, that's a great question. And so we do know that there is what we call variable penetrance, which is exactly what you just described. So, some patients who have the genetic mutation get the disease, and other patients who carry the same mutation for whatever reason don't develop the disease. And we don't know why that is the case. In terms of your question about the percentage, again, we don't really have figures, firm figures. What we do know is that there are certain mutations that have that are associated with greater penetrance than others. So there are certain mutations where if someone carries the mutation, they're highly likely to get the disease. And there are other TTR mutations where, that's far less likely. But we don't really have exact figures for each mutation at the moment. Again, I think that data will emerge as we learn more, but at the moment we really don't have firm data on those figures.
Hi, Dr. Gilmore. Segue to that question on penetrance. I was curious if you could comment on potentially unexplored therapeutic pathways, perhaps related to epigenetic regulation of the TTR gene, and whether in those patients where it's not penetrating, is it perhaps regulated like a closed promoter, perhaps, getting really technical, or if there are other mechanisms around proteostatic mechanisms of TTR regulation that lead to controlled degradation so it doesn't accumulate further. I'm curious, what are your thoughts in looking into the future, other pathways that haven't yet fully been elucidated?
Yeah, no, your question's a great one, isn't it? And I think there's so much that we have to learn and so much more to understand. I think we have always, one just simple avenue, if you like, is that we've always thought of amyloid as a disorder of protein folding. And, if you carry a mutation, if you like, if you carry a genetic mutation in your TTR gene, we know that your TTR gene is probably a bit less stable, more likely to fall into monomers and therefore misfold and form amyloid. But, what we haven't really thought about is amyloid as an immunological or as a failure of the immunological system. And it's very plausible, I think, and we're starting to think about this in our center. It's very plausible that actually, everyone gets a bit of ATTR amyloid as they age. We know it's very common in elderly people to have some ATTR amyloid. And maybe the people who get, overt disease are the people who are not very effective at actually clearing ATTR amyloid. And, maybe lots of people have antibodies against ATTR amyloid when they're young, but for whatever reason, when they get older, those antibodies disappear, and therefore, when they make ATTR amyloid, they don't get rid of it. Do you see what I mean? So I think, there are so many aspects of what you've just talked about, epigenetics, other genes that may influence expression, all sorts of things to look at. And I think it's, we're only at the early stages at this point in time. And, it may well be that, we need to be thinking of amyloid as a disorder of protein folding, but also a disorder of protein clearance.
Any more questions? All right, thank you so much, Professor Julian Gilmore.
Thank you very much. Nice to talk to you.